Hello, today I'm gonna talk about immunosuppressants, mainly the name and then the mechanism of action and then the side effect, what you have to know. So these are the drugs that are used for transplant rejection. So I'm actually in the shower room because they're painting the bathroom. So here. So these are the drugs we use for transplant rejection. So what are they? Steroids, cyclosporine, tacrolimus, sirolimus, azathioprine, mecophenolate monodial. And sometimes they like to confuse you, so they give these two as an answer choice, methotrexate and cyclophosphamide. But these, even though they are immunosuppressant, they are not used for the transplant rejection prophylaxis. They're usually used for rheumatoid arthritis or any type of vasculitis. So in the question, if you see both of them, it's automatically crossed out, right? So let's look at some mechanism of action. I memorized them in a group or two. So the first two group is cyclosporine and tacrolimus. The second group is sirolimus and diclizumab. And then the third group is mycophenolate monodial and azathioprine. So the first group, cyclosporine and tacrolimus, both of them eventually inhibits calcineurin. Calcineurin stimulates IL-2 and it increases the inflammatory transcription, right? So if you inhibit those, then what it does is it will reduce the inflammatory reaction. That's how it works for the immunosuppressant. So cyclosporine and tacrolimus inhibit calcineurin. Cyclosporine binds with cyclophilin and inhibits. Tacrolimus is also known as FK506. It binds to FKBP binding protein and it inhibits calcineurin. So both of them are calcineurin inhibitors, right? So these two are commonly used, but you never combine them. Why is that? Because both of them are extremely nephrotoxic. So one is enough to almost destroy your kidney. So do not use combination. Both of them has the same type of side effects like neurotoxic, diarrhea, diabetes, hypertension, hyperglycemia. But cyclosporine has increase in hair growth and gum hypertrophy. Tacrolimus have none of those, but it has increase in neurotoxic, diarrhea, and hyperglycemia. The next group is sirolimus, which is also known as rapamycin. It also binds to FKBP and it inhibits the mTOR. mTOR also stimulates IL-2. So sirolimus, remember, is an mTOR inhibitor. And the other thing is the monoclonal antibody. Anything that ends with like daclizumab, basilizumab, any zumab are monoclonal antibody that inhibits the IL-2 receptor, right? This will eventually stimulates mTOR, so it also inhibits. The side effect, pancytopenia, like pancytopenia, insulin resistant hyperlipidemia. The important thing is it's not nephrotoxic. That means the burn is normal, BUN is normal. So you can actually use sirolimus with either cyclosporine or tacrolimus as an adjuvant therapy because it's very safe for the kidney, right? What are the side effects of the IL-2 monoclonal antibodies? They have a bunch of side effects, but let's just memorize the unique one. The unique one is skin rash, flu-like, and lymphadenopathy. Skin rash, flu-like, and lymphadenopathy. So, and then the next group I memorized. So I memorized that two groups, right? So cyclosporine, tacrolimus, sirolimus, and desilizumab. The next group, as I memorized, is because the immunosuppressant, a lot of them cause bone marrow suppression, right? We know methotrexate causes bone marrow suppression, but remember methotrexate is not used in transplant rejection. So if you see that, then cross it out. So sacrolimus is pancytopenia, right? But kidney safe. Mycophenolate, the mode of reaction is reversible inhibition or IMP dehydrogenase. So it decreases the purine synthesis by inhibiting the IMG dehydrogenase. This drug, if you ask me, is really bad because not only it causes bone marrow suppression, it's not kidney safe, it increases cholesterol, it increases glucose, it increases BUN, it's associated with CMV infection. Azithioprine, everything exactly normal, like everything is normal, burn, glucose, hypertension, all normal. It has, the unique one is bone marrow suppression and dose-related diarrhea. So watch out, also remember azithioprine, it acts on the, it gives 6-MP, which needs to be degraded by xanthine oxidase inhibitor, right? So 6-MP is a purine inhibitor, so that's how it's the immunosuppressant. But 6-MP is degraded by xanthine oxidase. But if you're taking allopurinol for gout, allopurinol inhibits xanthine oxidase, so it can increases the azithioprine toxicity. So to recap, 3 groups: cyclosporin, tacrolimus. Tacrolimus doesn't have hyperuricin or gum hypertrophy. It increases the neurotoxic diarrhea and diabetes. Sirolimus, pancytopenia, kidney normal, monoclonal antibody, skin rash, flu-likes, and lymphadenopathy. And then the bone marrow suppression, this causes bone marrow suppression, but renal safe. Macrolonate is renal not safe, bone marrow suppression. Azithioprine, look for bone marrow suppression with dose-related diarrhea. So that is the topic for immunosuppressant.